Hello, everybody. Recording live from somewhere. This is Zach Couples with episode number 29 of the Movement Debrief. We got a good one for today, fam. We got three things on docket, maybe more. Who knows? It depends on what y'all want to ask me. We're going to talk about hip flexor tightness. We're going to talk about medial tibial stress syndrome, and we're going to talk about real-world physical therapy. Ooh, what does that mean? Stay tuned. But first, a little bit of housekeeping. Did you guys see my blog that I put out this week? So this week, man, it took me a while to write, but I decided to go through and figure out where do I learn from? And because I just have a bazillion people say, hey, Zach, what do you recommend for this? Or, hey, Zach, what do you recommend for that? That's free. Or so on and so forth. So I decided to just write it all out. So if you have that question, we'll just go look at the resources. And the goal with the resources page is to continue to update it based on when I find new resources or perhaps better resources. So you fam, you made it. You better get your weight up, son, if you know what I'm sizzling. Keep getting after it. Keep making the resources better so you stay on the list. That will take people off if I find better. So I think it's a good way to hold all of us accountable, and hopefully you guys hold me accountable, continue to get better. So that's that. What else? The human matrix is September of next year. I always forget the dates. I feel like every time you guys listen, I forget the dates, but it's like official. It's confirmed. It's the 15th and 16th of September. And it's going to be good. I did a lot of thinking over the weekend after I attended Pat Davidson's course in Austin, which we'll talk a little bit about that today. But I think I have the outline down in terms of what I'm going to talk about, and I hope you guys like it if you attend. So if you do attend, stay tuned. Once I get the registration up, I'm going to send it to everybody and their mamas and their papas. This past week, though, I attended a talk, a 2-day seminar by the one and only Pat Davidson, and it was in Austin, Texas, and it was quite good, very, very good. Just a sneak preview. I'm going to do a full review and all that, but tell you what, that fan be smart. He knows some stuff. And I would strongly encourage you guys, if you're not already following him on social media, you ought to probably do that. I also had, well, his class was good. I was also there for a few days filming some stuff. Stay tuned. But I have to give a shout out to my people, my wonderful people. I want to give a shout out first to Dave Rasco. I met him for the first time, and I had the pleasure of staying with him, working with a lot of his people. If it weren't for him, I wouldn't be where I'm at today with a lot of this internet stuff. And he's just a very important person in my life. So thank you, Dave, for making that a possibility. And I'm so glad I met you in person. 2DU is all right, 3DU way better. I also want to give a shout out to Lucy Hendricks and Dee Will. Those are also some peeps that I met for the first time in person, who I've been working with quite a bit online. So, and they're just outstanding people. And of course, Tom from Enhancing Life. I'm so glad I met you guys in person. I look forward to continuing to hang out. And all the other people I met, I met a lot of good people at the seminar. There's two May to May, and it's just, Austin's a good place. There's good people down there. Aaron Davis, how could I forget about Aaron Davis? Man, phenomenal guy. Good conversationalist. Please go check him out as well. But yeah, it was a great time. Really good time. So that's it housekeeping wise. Also, I don't know if you guys know this, but it is not ugly Christmas sweater, but it's cool Christmas sweater debrief. Number 29. So please be jelly. The force is with me tonight. Let's debrief. Hopefully I can concentrate. So, number one, first question is from Lucy DPT. She asks, do's and don'ts, not to be confused with donuts. Good clarification. I'm glad you liked it, Chris. Do's and don'ts for hip flexor tightness is a topic of interest to me. Lucy. It just so happens to be a topic of interest to me as well. So, let's talk about what hip flexor tightness means. Now, I'm not, and maybe this is Daddy-O Pops just biasing me, but I don't know what tightness means because I think you can be perceiving tightness and have a limitation of movement or have excessive movement. So you can have, hip flexor in a concentric or an eccentric relative position. But for the sake of simplicity's sake, let's say that we have limitations in movement into hip extension that we would think implicates the hip flexors. So what do you do for that? First off, how do we assess this? Check out hip extension. What I use to check hip extension, just because I'm lazy and it's an efficient test, and you can check a lot of other planes with it, is I use an Ober's test. And so with the Ober's test, obviously you have to be able to pull the hip into extension. If you can't do that, you probably have hip flexors that are a bit overactive, right? Potentially. Could be secondary to position, I don't know. But we're just going to look at the hip. Obviously you have to take into account thorax and stuff like that. So you look at the Ober's test. And then here's a little trickery. So let's say that that's positive. You can kind of determine what your next step will be from an exercise selection point by doing one key move. What is that move? I'm glad you asked. The move would be extending the knee and then checking hip abduction. If you can pull the hip back into extension once you extend the knee, then you potentially implicate a joint or a muscle that crosses the hip and the knee joint, which that would be the rectus femoris, right? Potentially, right? I mean, there's probably a lot of other things involved. Who knows, right? But you would look at the rectus femoris as something, maybe I need to do something that addresses the mobility of that, or the tonicity of that. That's probably a better word. And so that's what I look at to determine what do I need to do from a hip flexor standpoint. The treatment, I mean, it's pretty simple. We know that as the pelvis tips forward, the hip flexors get a little bit more active because they're kind of anti-gravity muscles. And what you do in that regard is do things to get those to relax. What would that be? Well, if the pelvis is forward, I got to tilt it posteriorly. Here's where the knee flexion extension piece comes in, because that will give you some insight in terms of what joints do I need to emphasize, or what muscles that cross both the hip and knee joint do I need to emphasize to get those to chill. It's simple principles of reciprocal inhibition in this case. And so if I cannot extend the hip, I'm going to do some move that involves a posterior pelvic tilt. Right. Daddy-O, clarification. Are you not just confirming concentric orientation versus tone? Yes. Yes, that's a good question, Bill. So Bill Hartman, Daddy-O Pops, asked if I'm confirming concentric orientation versus tone. I would say it's definitely concentric orientation. But I would also say, based on concentric orientation, would you not also see an increase in tone of the hip flexors? But then again, too, you could also have a situation where there's eccentric orientation of a hip flexor versus tone as well. Or actually, it wouldn't be the hip flexor, it would probably be anterior hip capsule, now that I think about it. I would say concentric orientation. Oh, damn it, Bill. And so I would say with hip flexor tone, I mean, you know what, I don't have a good definition. It's kind of one of those things where you I don't know. It's like define fitness. I don't know. It's just an esoteric term, and maybe because it's an esoteric term, it shouldn't be used. So we'll say it's an orientation-based thing. But anyways, if you find that you have a limitation in hip extension, and let's say that limitation is still present with knee flexion, then what you're going to do is do activities that potentially bias both joints, right? So what would that look like? I would potentially do a move where I'm extending the hip and flexing the knee using the hamstrings based on reciprocal inhibition to see if we could make that move better, right? And I would start with that. And if you do that and couple that with posteriorly pelvic tilting from the bottom up, so by utilizing the abdominals via establishing a normalized infrasternal angle, combination of those two things ought to alleviate the relative hip flexor tightness. Because if you can favorably influence position, then you're going to be in business. Basically, if you have a limitation in hip extension and it doesn't change with knee flexion extension, you should probably need to do things that reciprocally inhibit that. So I'm looking at hamstrings, and it's just a matter of if you need to use a knee flexion-based activity with the posterior pelvic tilt, or if you need to bias the hip into a bit more extension. Typically, I won't bias the hip into more extension unless I can't get the same change that I need with the hip more so flexed. So think like a Levitt position or Skywalkers, if you're familiar with Bill Hartman's book, All Gain, No Pain. Those would be the types of things that I would be considering utilizing. And so that's kind of what my thought process is in that regard. Because when you extend the hip, you have greater tendency to extend the entire body. And so you just have to be mindful of that, especially if you're kind of bumping into end range sooner with the hip flexors. So just something to think about. So basically, you got hip flexor tightness relative. Use the hamstrings, use the hamstrings, use the hamstrings. Okay. I also apologize for the discombobulated broadcast. The internet is just not loving me today. Okay. Next question comes from Zach. And I already like this guy already because we share the same name. So Zach asks, management of medial tibial stress syndrome for athletes and contributing factors besides just the provocative activity or excessive volume of activity. Things you prioritize in evaluation or educational information you like to emphasize to the patient or family. This is a large issue with our high school athletes in our area, and especially those who transition from basketball to lacrosse on turf fields. Okay, that's a good question. And Zach, as you'll find, my process doesn't seem to change that much, even in that case. Let me unpack that a little bit. So the first thing you got to do with these types of things, the medial tibial stress syndrome, is you need to make sure that you can help them. And make sure you rule out conditions to where you can't help them. So what would that be? Maybe a stress fracture. Because maybe that limits what you can do in the PT realm, and you might make them worse by doing that. So we have to address that first and foremost. Obviously, you should look at history and all these things, but I think there's also some decent objective testing you can use to potentially implicate a stress fracture. There's 3 things that I mess with. Tuning fork. Now, let me preface this. It's been a while since I've looked to see the sensitivity and specificity of these things, so there could be better options out there. But what I'm familiar with is the tuning fork, number 1. So you hit the tuning fork, put it over the area that's potentially sore. If there's a pinpoint area that's tender, you may be thinking, yeah, this might be a problematic. John, I will answer your question. So you want to do the tuning fork over the area if the person is in excruciating amount of pain. you may want to refer out. That's one thing. Ultrasound's another possible thing to look at. There's a very similar response because of the ultrasound. You get the kind of a shakiness in bone. That could cause where the area of the stress fracture is to shaken, and that would really hurt. So there's that. And then another one, pretty cool, a little underrated. I picked this up from my boy, who has probably the best mustache in physical therapy, Bill Boysenall. And basically what you do is you put a stethoscope. If I'm looking at the tibia, on the medial malleolus, you put the stethoscope there, put the earpieces in your ears, and then you tap on the patella. And you should hear a symmetrical sound on both sides when you do that. If you don't, you might have a stress fracture. This should probably go for some imagery. So what I would do is I would do the cluster of those three tests, or maybe you do like the tuning fork and the tap test, because if you make that person hurt with the tuning fork, probably not going to let you do the ultrasound. So pick one of those two. If that's the case, then you probably want to get X-ray and the CT scan. CT seems to image bone a little bit better than X-ray. So those would be things that I would consider looking at first off the bat. Rule out that you have a stress fracture. If you don't, and you don't think that the history matches that, and all of those tests seem to be negative, it's worth giving a PT a shot. And the treatment paradigm is the same as it would be for anything else. Variability first, well, knowledge first. So if you got someone who's got some impairments in pain, or pain education or maladaptive beliefs that are preventing movement, de-threaten those. Check out my talk if you want to learn more. Then you got variability. Do they have all the requisite degrees of freedom to express movement in three planes? Power and capacity. It's the same process. So make sure you are restoring variability to the best of your capabilities of the axial skeleton. Work your way down to the appendicular skeleton and then build power and capacity. Now let's talk a little bit more in depth about the variability side of things. So with that, if you've restored this all the way down, everything else, what you'll want to potentially look at is femur position relative to knee position. Because what can happen sometimes is you may have a femur that is biased one direction from a rotational standpoint, and you might have a tibia going in the other direction from a rotational standpoint. And that could potentially put stress in some individuals along the medial tibia, because that bone gets loaded a bit more effectively based on the angle that the tibia is going into. And so I would look at that. And how would you look at that? Check hip internal and external rotation so you get an idea of what direction the femur is potentially going. And then after that, you can also check tibial external and internal rotation. If you see a limitation in that, then what you have to do is you have to untwist the tibia. So I was talking about the relative twist in the knee before the internet hated me. And what you want to do is check hip internal and external rotation, check relative tibia external and internal rotation, and basically what you want to do is untwist it. So let me give an example of what I would commonly see in a medial tibial stress syndrome type pattern. What you'll typically see is an increase in internal rotation, loss of external rotation at the hip first, and then you would see the femur trying to go in the opposite direction. So the femur, or the tibia I should say, will go in the opposite direction. So you'll see an externally rotated tibia. And so with that, here's what you got to do. You got to put them in a position where they essentially teach themselves to derotate. For this, I really like lunges. So I would put the tibia in relative internal rotation. And that may be just pointing directly forward. Press down on the arch, externally rotate the femur, relatively. So we derotate things. If you have the opposite case and you think that that's leading to a tibial stress syndrome, so for that we're thinking femur has loss of internal rotation, tibia has increase internal rotation. So you have femur externally rotated, tibia internally rotated. You do the opposite. You center the foot, because that would put the tibia in comparison to what we're doing to the femur in relative external rotation, and you would IR the hip. And that's how you would do it. So basically, rule out bad stuff, address variability, derotate the knee so you have better forces going through the tibia, and you ought to be in business. One thing you could also potentially consider is modifying shoes. So for that, if you feel as though you can't derotate the knee because of the way the foot is oriented, so maybe you have someone with a super high arch and they just cannot pronate to create the tibial internal rotation. Maybe you put like an arch support or something like that underneath the foot to see if we can get a change. On the other case where maybe you need to externally rotate the tibia, maybe you do something to lift the foot up, whether that's a heel wedge or like a medial wedge, or even using an arch in that case, just to give them some contact. That can also help with derotating the knee. So those are things to consider. Once you've kind of addressed variability and you think that, hey, this isn't the problem, then it's just a matter of gradedly exposing them to whatever it is led to the stressful event at that point in time. And this is where I think acute chronic workload comes into play. It's very important. It's something that clinically I typically, now I haven't figured it out completely. I think it's much easier to implement in pro sports because you have many other measurables that you can look at. It's, in my experiences in the clinic using this thing, I'll obviously use a combination of internal load where I'm doing like maybe session duration times rating of perceived exertion to figure out a number. I just don't, like, external's been kind of hit or miss for me. Typically when I use it, it's like a return to run program. But what you have to consider is that when you're looking at acute to chronic workload, it has to be specific to the task being performed. And so one error that I made when I was in the league and when I was managing mostly the D League, because that's where I learned a lot about the acute to chronic, I took into account everything they were doing and called it one unit. So with that, I was looking at weightlifting, practice, and games. And like that was an error on my part because those are completely different things, requiring completely different energy system combinations, different forces, all these things. And so it was really a comparison of apples to oranges and pumpkins because there was 3 variables. That's the third thing I had to think of. So you can't do that. But I've even found, like I had a guy who I was doing this with because he was trying to run a fast mile. And he was battling a couple of injuries towards the end with like some hamstring stuff. And it just wasn't matching on the acute to chronic. And I'm like, I don't know what's going on or what other factors are going on that are potentially leading to this guy having pain with increased load. And where I erred with him was even equating speed work and distance work. Because again, the forces are different. And you can't get an accurate comparison. So it's almost like what I needed to do was have 2 separate calculators going at the same time, one for maybe distance-based running so we know mileage is good, and one for speed work. And just having more boxes to look at to potentially say, hey, we're moving in a safe direction, or hey, we're not. So, Zach, in the case that you're talking about, if it's lacrosse, maybe it's a little bit easier, or if it's another sport like that, because you're just dealing with that sport. But I would say if you're using acute to chronic, you have to have a separate tally going for practices. You have to have a separate tally going for games. You have to have a separate tally for going for general physical preparation stuff. And ideally, if you can measure external and internal load, you're going to be safer at saying that I can progress this person in a in a safe fashion with minimal risk of harm, because that's the one thing where people falter the most with these types of things is they do too much too soon, or they don't have a scientific way of progressing things. And I think acute to chronic has a lot of potential. We just have to figure out ways to apply this in a manner that it's accurate for the common man and woman, or just Joe Schmo practitioner like me who doesn't have catapult and stat sports and RFID. And I know we don't have that at the high school level for lacrosse. So in the case of these types of athletes, like for an external load, I would just look at practice time, and maybe if, I don't know, you count number of drills. I really don't have a good answer besides practice time. And then rating of perceived exertion is huge for the internal load side of things. If you do that, time, session, duration. But I think in terms of what your measure is external-wise, it really is sport dependent, and it's probably even within the sport modality dependent. So I think to do it right, it really takes a lot of monitoring and a lot of work. And I know that's not like a sexy answer by any means, because it's hard. And this, what we do is hard. But I think you have to do that in order to be successful. And so whether it's monitoring that, monitoring sleep levels, monitoring all these things, you kind of have to look at everything. So to summarize that point, Shami, your question was not answered. So to summarize that point, rule out bad stuff, address variability, build power, work on capacity, and then use a graded return via acute chronic workload to get them back to play. Next question comes from John Murray 64. Not to be too Tweet Pete, he asked me a question before, but also if you were to tell young buck SPT, that's student physical therapist, Zach Buttercouples. Now, let's preface this, John. I've never been called Buttercouples, but that's really good. Like Buttercup, Buttercouples, I get it. If you were to ask young buck SPT Zach Buttercouples advice about real world PT, what would it be? Or to tell young buck, I should say. That is a really, really good question. I told Bill when we spoke last night that I was going to answer this question, and I really liked his standard answer, and that's young Bill, or young Zach in this case, probably wouldn't have listened to old Zach, because I was probably too smart for him. But let's, for the sake of argument and fun, let's just say that young Zach would listen to me in terms of the advice on what real world PT is. I think the first thing I would tell him is, hey dude, don't spend so much of your student loan money on stupid stuff, and try to come out as unscathed as you possibly can. And the reason why that is because those were great too. Daddy-o Pops is a very good rule of thumb that I also live by, which is don't get married, don't buy a house, don't have kids. So I'm going to like that shit. But come out unscathed. And the reason why I say come out unscathed is because having worked in PT for 6 years and seeing where the direction is going, I think the way healthcare is going, in the sense that there's less time being spent with patients, you're having to see more patients at once, all of these things, it's really a bleak model. And it's a very hard model to be successful in. And I think, young Zach, if you want to do healthcare the way you know you need to do healthcare to help people, you have to do it on your own. And you have to do it outside of the system. And when you have the student loan debt that I do, it's tough for me to justify taking that risk, because fam got to pay off student loans. And so that has to be addressed, right? I have to be able to get to a point where I can do this on my own without relying on the system to pay me, because that's the only way we can help these people. And patients aren't getting any easier to work with. You have multiple comorbidities. You have multiple skill sets that need to be used on people. How many of us are we addressing sleep with? How many do we talk nutrition with? How often do we talk about social interaction, strength conditioning, all these things? That's just outside of rehab. That's important to the rehab process. So I don't have a good answer. That type of model, the model that I aspire to do, where I am helping someone with all of those areas, I can't do that in insurance-based PT. I just don't have the time. A lot of that stuff's not covered, but it's going to be essential to help people. So that would be what I would say about real-world PT, is that we have to transcend PT. We have to, sorry, Dad said the feed is breaking up, so I'm going to just try to keep going. We have to transcend what our degrees are in order to effectively help people. And to truly get the best outcomes for people, we have to do it outside the system. And so that's really what I would tell young Zach, is get to that point as soon as you can. That's really what I'm trying to do with my online stuff. So that was a great question by John Murray, 64 from Twitter. All right, Shama, I believe you asked, I can't remember, I think you asked something with low back pain after biking. And be a generalist first and foremost. Dad, I agree so much. Because if you can hit all the general qualities, and really, if you address movement, sleep, nutrition, stress management, and social engagement, all of those qualities have the largest systemic effects. And so that's what generalism is about, is having a systemic effect on someone. And when you are a specialist, you don't have those systemic effects as much, I don't think, unless the local input that you're giving, whether it's a total hip or whether it's doing something to the kidneys, those don't always have systemic wide effects, but building good habits into people does. So that's a good point, Bill. Shama, low back pain from teaching 6 spinning classes per week. Ooh, that's a good question. Man, well, I would say if you're in the hunched over position a lot, I'm thinking, again, just like with anything, what's your rib cage looking like? So one thing I would test on yourself is, how prominent are your ribs? Do you have kind of a narrow rib cage? Do you have kind of a wider rib cage? Ask yourself that. Because what can happen is, as you try to bend forward, if you don't have access to that movement secondary to orientation of the rib cage, your back may be a little bit more active, especially as you fatigue. And so what I would do and what I would encourage is, if you have a wider rib cage, think arms overhead, forceful exhale before you hit the bike, and maybe even after the fact. That will at least take you out of that prolonged position. If you got a narrow one, get on all fours, and I'll link these to the show notes, but get on all fours, push, reach, open mouth, long, slow exhales, get the air out. You should be in business. But check out tomorrow's show notes when I put this on the blog. Yeah, I think that's probably a good stopping point for tonight. I apologize for the feed. I don't know what's been going on today, but the internet gods have frowned upon me. That's okay. Maybe next week will be better. I will have this up on my website though, so no sweat about that. But I want to thank you guys for tuning in. Where can you learn more about me? First off, go to zachcouples.com. That's my website. Sign up for the newsletter. You'll get access to exclusive talks. One that I talked about, my practical pain education talk, and a talk on respiration. It's like almost 3 hours of content and almost 50 pages of notes. And it's gotten some pretty good reviews from people. So you should check that out. One. While you're there, I also offer online services. If you need mentoring, if if you want mentoring, if you have some movement issues that need addressing, if you want training, click on the online services page. Check out the information there. Got a few testimonials from some people who I've worked with. You can also check out or talk to Lucy Hendricks, Dave Wilton. You can talk to Dave Rasco. You can talk to Trevor Lassar. You can talk to any of those people because I've worked with their clients online, and they'll be able to tell you what it's like. So go ahead and check that out. Check those people out. Andy McCloy as well. He'd be another good person to ask because I worked with some of his people. Check those guys out. Ask them. They'll give you an idea in terms of how the movement consultation process works. Jordan, my boy, he's watching right now. He's in that mentorship program. We had an awesome session this AM. If you want to learn more, like, reach out to these kinds of peeps, right? That would be what you could find on zachcouples.com. After that, find me on Facebook, facebook.com/zcouples. I would also check out /ZachCouplesPT because I'm going to be slowly migrating all my stuff to that. And then I won't be doing as much of the personal jazz. Kevin, what's up, fam? Happy holidays to you too, my guy. Man, it's been too darn long since I've seen you, even though I saw you this year finally. We'll have to make that happen again soon. So there's Facebook. You got Twitter. The handle is @ZCouples. I also have that Instagram, baby, which is Zach, Z-A-C Couples. And if you go to YouTube, type in Zach Couples. There's videos of exercises and stuff that I put up, so I would definitely check that out. Respect it, don't neglect it, Kevin. Otherwise, thank you guys so much for tuning in. I hope the holidays treat everyone well. I hope you guys stay hungry, stay learning, stay moving, and I'll see you next time. Deuces!